Welcome, everyone, to the Metabolic Resuscitation webinar sponsored by PNOE. Before we get started, I would like to share that any questions will be addressed at the end of the webinar. If you do have questions, please use the Q&A icon located in the Zoom toolbar. Today's webinar will be recorded and available on the A4M website for your convenience. Now let me turn it over to panelists to start with our webinar. Thank you for being with us.
Thank you so much. And hi, everyone. Very excited to be here. PNOE, as probably many of you know, is a company focused on VO2 Max and metabolic testing through breath analysis. We are credited for developing the world's first portable, low-cost, and clinical-grade cardiometabolic analyzer, aka VO2 Max or metabolic testing device. And today I'm very fortunate to have with me in this discussion Dr. Donald Bennett, who is a longtime PNOE user and has had a ton of experience utilizing VO2 Max and metabolic testing in the process of optimizing people's health, whether that is enabling them to achieve better performance or enabling them to train for life and achieve longevity. A little bit about the discussion today. It's going to be obviously about VO2 Max and how VO2 Max testing can support one's health journey and helping them optimize nutrition, training, and other parts of their overall regimen, as Dr. Bennett is going to talk about. But as we discuss about VO2 Max, we're going to dive into several concepts of cardiometabolic testing, and specifically the fact that cardiometabolic testing, unlike what most people think, is not just about VO2 Max and resting metabolic rate. In other words, it doesn't just measure your VO2 Max and basal metabolic rate. It's actually an assessment that analyzes 23 different biomarkers that ultimately reflect the health of the oxygen chain. The oxygen chain meaning the conglomeration of systems comprising your lungs, your heart, your cells, and your nervous system, which is effectively the system that channels oxygen in the body and clears carbon dioxide. So just wanted to put that out for people to understand, because it's going to be a very important concept as we discuss the different utilities of the test and how the insights can be applied in order to optimize one's health journey, as we said. Turning it over to Dr. Bennett. Thank you again for being here and excited for this conversation.
Yeah, Panos, that's a great introduction. Thank you. I think now we're doing more tests. We're like the leading tester in North America now. Is that correct? I think
you guys are up there. I would say that there is one new client that we onboarded in Mexico, which has actually mastered the business model that we always recommend to our users, which is give the resting test for free and utilize the feature that we have in our reports, which is to weave in the report the services and the supplements and the IVs that you have. By the way, folks, this is something that you should look into in case you haven't done so. So he has 25 clinics, very high throughput of people giving out the test for free and then utilizing the test to upsell supplements. I think this guy right now holds the record for about 900 tests in 1 or 2 weeks. You guys are doing well. You guys are doing well, but he broke the bank.
He did. That's fantastic. I know for a while we were doing a lot, and so I'm going to go ahead and share some slides, and we'll get talking about kind of the journey and how we put together utilizing all this to really help our clients. So let me share these slides, and full disclosure, I'm a partner and founding physician for MOOV. MOOV is our organization, and we are wholly physician owned. So we're not owned by anybody else. We get to determine the care that's done. We don't have venture capital. We don't have investors. We we, the physicians, are the ones determining what we're going to do, which has given us a lot of opportunity as physicians to decide how we're going to roll out the testing and the things that we're doing with our clients. And so we've coined it metabolic resuscitation. The majority of our physicians came from emergency medicine. So we have a resuscitationist mindset. We saw patients all the time coming in, and because they weren't living the precepts that we teach in A4M and in other places, we were trying to save them so they could get out of the hospital and change their lives after that. And in this same light, we started applying those same skills and the new knowledge we were gaining by going and doing fellowships and more training and learning new things to our clients at MOOV. And I coined it metabolic resuscitation. So kind of my origin story, I was an emergency medicine physician in the Navy, deployed with the Marines a lot of times. And, after I left the Navy, I started struggling with my health. And you can see this picture here in the middle. It wasn't my finest moments. We were having fun, but then I started the A4M fellowship and started applying these types of metabolic resuscitation precepts into my life, including using the data from the VO2 Max. And it was like I found the cheat code on how to stay healthy. And I wanted to start sharing that with as many people as we can. And so now we have 7, almost 9 clinics across the United States where we're continuing to bring people in and do this. So, did fellowship training with A4M, American Board of Anti-Aging and Regenerative Medicine, and I've been doing this integrative practice. Let's talk a little bit about what we do and how we set things up. So we really wanted to peel apart this in-depth assessment. It's not about one thing in our health. It's not about how much do you weigh. It's not about your body fat percentage. It's not about this one marker, this one thing, because as we know from breath analysis, it's a whole chain of reactions that have to happen for you to be healthy. And so for you to perform physically day to day, or when you push yourself in a fitness, you have to be able to utilize everything from the beginning to the end. And so we start out actually by doing a VO2 max assessment. We have the resting metabolic rate that we do for many of our clients. We do over 100 biomarkers, from lipid NMRs all the way through vitamins and hormones and inflammatory markers, because each one of those markers that we put into place to look at for the patient really do matter. And we see the difference in our VO2 max assessments if we get those things right. We follow our clients also with a bioimpedance scan. And then, they spend like an hour with our physicians, sometimes more if they're more complex, to get that information. So, I'm going to turn that down here, but you can see, we do these assessments all the time. What is VO2 max assessment? How does this work? And I think Panos, you're probably the best at explaining these things, but VO2 max is a measurement of our oxygen utilization at the cellular level. How are we able to do that? And when our body's working efficiently, we're able to utilize that oxygen in an efficient manner. It became the gold standard for aerobic fitness and longevity. And even in 2016, the American Heart Association established it as a vital sign. What's interesting is that hasn't penetrated into normal medicine. That has not got down to the granular level. Other physicians just aren't putting this into practice on a daily basis. And there's some barriers there. We all see those barriers. One is time. One is training and understanding. Physicians are afraid to make mistakes. We don't want to make mistakes because we fear that the outcome will be a negative. So if we do the test and we mess it up and we have to repeat it, that feels like we're failing the exam. And I think we have to break that model as new technology is rapidly coming into our setting as physicians, where we can utilize something like the PNOE device to get this critical information for our clients so that we can change their lives. Why we want to identify the true heart rate zones for efficient training. We want to look at what those actual markers are for those patients. The calculated data is just not correlating with our patients, and we'll talk about that calculated data and where it came from.
And Dr. Bennett, if I may pitch in just for people to maybe get a better understanding of what is actually being tested during the assessment, because I alluded to that earlier. But I think if I share my screen just for a second, you guys will be able to get a better understanding of the information that one can elicit from the test. As I was saying earlier, VO2 Max or cardiometabolic testing, or in the clinical world, it's also known as cardiopulmonary exercise testing, has been around for about 100 years. It actually predates blood analysis and effectively measures three main signals: your flow volume, so it's basically a spirometry test, but at the same time, it's also looking at oxygen concentration and CO2 concentration in real time. So you're basically recording the waveforms of the flow volume, CO2 concentration, and oxygen concentration. So think of three sinus-like signals that you will then analyze on a breath-by-breath basis, and you will determine the 23 biomarkers I referenced earlier. Now, these 23 biomarkers, one of them is VO2 max, another one is basal metabolic rates, another one is fat and carbohydrate utilization, another one is the so-called O2 pulse, which is how much oxygen your heart can pump in the body per heart rate cycle. Another one is minute ventilation, which shows us how much CO2 you're discharging per breathing cycle. And so all of these metrics have been established in the clinical literature and the scientific literature over the past almost 50 or 60 years as critical biomarkers for different parts of our body. And so we haven't really come up with any of the science behind the report you're looking at. All we've done is we've codified the analysis, we've codified the connection between these biomarkers and specific insights about different parts of your body, and we've made it palatable and understandable for the end consumer. And so what I mentioned earlier is that by looking at all of this information, you're effectively able to analyze the oxygen chain, right? Which is sort of the basis of our body, because effectively it's the channel that enables metabolism to occur. In other words, the channel that enables oxygen to be delivered down to the cell in order for fats and carbohydrates to be oxidized, release the energy that we need, and then discharge the CO2 that is being produced through the process. And that is the overview page of the report. We try to summarize the fact that you're actually looking into the conglomeration of these systems, and we just go next to each system and connect the score that is the most associated with a specific system. And so by looking into all of these 23 biomarkers coming from your breath, plus there's actually 3 biomarkers coming from the chest strap that we give you. We're looking at heart rate, but also low frequency, very low frequency, and high frequency component of heart rate variability, from which we can derive sympathovagal balance. We're also able to see the connection between your nervous system and your breathing. That's actually a very, very interesting connection. And there's actually a lot of meat there and insights that very frequently arise from the tests that we deliver. And so you can very clearly see here, you're doing the test, you're getting your scores, and through your scores, you can understand where the problem lies. The biggest issue with most assessments that are available right now in clinics or any sort of health center is that they're not prescriptive and they are not specific enough to tell the person what system is deficient and therefore is leading to a deterioration of overall health. VO2 max, as Dr. Bennett mentioned, is undeniably right now, according to the current state of scientific knowledge, the best predictor for longevity. And as a result, it is probably the best marker that we have for overall health. But VO2 max alone will not tell you what system under the hood is deficient, so that you can actually make changes and improve it. By doing, however, the analysis of all 23 biomarkers, you are able to determine the limitations that you have, whether these are in the lungs, in the heart, in the cells, in the circulation system, nervous system, etc. And by identifying them, you can actually start to strategize in terms of the nutrition, the training, or whatever other modality you are in the business of providing. So that was just like a short summary of.
If you could even go down and do you have the page that shows the carbohydrate utilization based on zones, carbohydrate and fat? It's absolutely fascinating to me. You bring this up, and we utilize this all the time. We change people's fueling regimen based on this. So endurance athletes will come to us, or people who are just not performing at the gym. And we'll look here and we'll be able to see their fat burn and their carbohydrate burn. And we're able to determine, hey, you're not a person that will do well working out fasted. You are just not going to perform well because your fat burn is so low in these lower zones. You need to come in with a small amount of carbohydrate load, and it changes their lives. And then we can look at the more performance athletes in zone 3 and zone 4, and we can predict what they need for fueling based on their outputs. Because
for instance, the person that we're looking at right here, you guys can see that, there is a very precipitous decline in fat utilization starting from zone 3. So this person is, to some degree metabolically compromised. You're basically looking at fat utilization at rest, but also during exercise, what Dr. Bennett is referring to, in order to understand the person's ability to switch between fuel sources, which in science, this attribute is referred to as metabolic flexibility, right? Our ability to switch between fuel sources, and also our ability to upregulate or downregulate energy consumption at the face of energy availability or energy scarcity, is basically the definition of metabolic flexibility. And studies now show time and time again that metabolic inflexibility is actually the starting point of any sort of metabolic disorder. So there are ways to assess that in the lab. Dr. Peter Attia talks about that a lot, specifically referring to the insulin clamp, which is a very cumbersome and invasive procedure. But there's actually a much easier and almost as reliable way, which is to understand someone's fuel utilization that can actually give you a very, very good understanding of how efficiently they can switch between fuel sources. And it's actually pretty straightforward if you think about it. A person who's not able to very rapidly adapt to energy intake, i.e. eating food, and therefore they're not able to channel the food that is being inserted into the system into the muscle in order for it to burn and actually be utilized as energy and a fuel source, what's going to end up happening is that these nutrients will be converted into fat. And this fat accumulation is what's going to ultimately create the toxins and the foundation for metabolic disorder to occur. So that's kind of the concept that Dr. Bennett is referring to here.
Yeah, and it's that pathway that we're trying to activate, that AMPK pathway to get that fat utilization, that fat burning going. If your mitochondria is unhealthy, the initiation potential that you have is so high that you cannot flip back and forth. And so then you inefficiently burn things. And none of us like to inefficiently burn things. When we do, we end up with a lot of smoke, and that those are toxins downstream, and we end up with a lot of inefficiencies in our body. And so it's fascinating how they all play together, and you get these insights by doing the testing. So we're able to really make those impacts.
Absolutely. So, Dr. Bennett, I think we should go back to your presentation. Just that was a short parenthesis for people to have like a better understanding, deeper understanding around, what the test provides.
We also, because this system is so complex and because there's so many things that go into it, we do many biomarkers. This isn't all of them. And we're able to take all that information and put it together to address these gaps in modern healthcare. And we're able to put those together to be able to make a comprehensive and overall, I think, I don't know what you think, Panos, but really a paradigm shift in how we look at medicine and how we assess people and help them achieve their lifestyle goals. Because if you have insulin resistance, if you have mitochondrial dysfunction, if you're cellularly unhealthy, you can't continue to stay healthy and perform at the level that you want. And then, of course, you fall into that invalid category very quickly, or you start having organ breakdown.
Yeah, 100%. And, as you said earlier, the American Heart Association openly recognized this type of assessment as a critical one and openly said that every person should be doing it at least once a year. And that was almost 10 years ago. It was in their official statement in 2016, right? So I think there is a lag between, the scientific observation or the observation from the medical community and actual implementation. And, this 10-year period sounds about right in terms of, how long things typically take to transition from sort of like a bombastic theoretical statement into something that is actionable and becomes, I wouldn't say standard of care, because I believe we're still very far from these concepts and these practices to be incorporated into day-to-day healthcare. But I think it's undeniable that this longevity and integrative medicine space is becoming sort of the norm for at least a part of the population. And I think the amount of people attending A4M, the amount of people attending our webinars, and the level of interest that we're seeing is actually evidence towards that.
Yeah, you talk about bombastic statements. When I was pre-med, I attended a lecture at Scripps, and they have an institute in San Diego. It's where they develop polio vaccine there. I mean, it's an amazing place. And this cardiologist got up and he said, if we're doing CPR, we should continue to do compressions and not stop and pack their head in ice. That would be the best thing to do. And he basically got laughed off the stage. This is 1992. And fast forward, to now, and he was right. It's just no one else had caught up to him yet. And I think that's where we are in a lot of things that we're doing. It's fascinating. I'm going to talk about glucose and insulin dynamics because of the carbohydrate fat utilization and how important that is. We did a test on a young man in his 20s, and he passed his VT1. So what does that mean? That means his ventilatory threshold 1 from when he moved into zone 2 towards zone that zone 2, zone 3 zone where he's passing his basic kind of low burning state to a higher calorie burning state where he's just passed on. He did that walking from the chair we had him in to go get on the bike. And we actually reset the test a few times. And I was like, wow, he's very, he's over 150 pounds overweight, metabolically unhealthy. We didn't have his labs back and so on. And we finally got the test done. I think he's a man in his 20s and his VO2 max was 19, or VO2 peak was 19. Very bad, very bad. And I got a call from your team. And they said, Dr. Bennett, is this test right? They'd never seen one that bad. And I said, yeah, he's very metabolically unhealthy. I think that he has undiagnosed diabetes because he was just coming in. We didn't have all his testing back. And sure enough, his fasting glucose was very elevated. His fasting insulin levels were very bad. And we could tell all of that just from the initial testing. We had so many things to
and just to piggyback off of that, because I think this case is sort of telling, but it's sort of a gateway into another very interesting population group that we very frequently run into, which is people who are, in contrast to this person who, from what we all understand, was like obese or even morbidly obese. So without running any sort of test, you could see this person and assume that you're going to find pretty much any possible issue. But I think the most interesting population group comprises of people that if you look at them without their shirt, you're going to think that they're super fit. They are quite lean. They're very athletic. Relatively young, between 35 and 45. But then you put them on a treadmill and you see that their fat burn efficiency sucks. And then in many cases, their resting fat burn also sucks. And then we actually run into these people all the time. And then they don't believe us when we tell them that you are very likely metabolically compromised. And, if you continue like that, you may end up developing, as you said, type 2 diabetes. And lo and behold, a lot of these people actually get their blood work done and they see fasting glucose with 95 plus, in certain cases, even notching up to 100. And most importantly, they see hemoglobin A1C, close to 5.7, which is considered like pre-diabetic. So it's not just the person.
Yeah, they're fasting insulin levels 18, 20, and we see this over and over again.
Yeah. So I just want to highlight that for people. Just because someone shows up and looks healthy, and in many cases even jacked, we're talking about people with, body composition, so a fat percentage of maybe less than 13 or 12 for males at least, which is quite athletic. It's quite lean, but because of a variety of factors, we can obviously touch upon them for a little bit, that have to do with very bad nutrition, maybe overconsumption of animal protein, overconsumption of toxins, lack of specific type of training, overstressing themselves, etc. They will end up developing this mitochondrial dysfunction that manifests, through poor fat utilization, and ultimately it's going to show up in blood work. And if the doctor just sees the blood work without seeing the person, they're going to think that this is a overweight person who is already diabetic.
Yeah, right. It's so fascinating because you could just never tell until you actually put it all together. People are so complex, and the wonderful thing about the case where the person that I had obviously was metabolically unhealthy. They're metabolically deranged, all the way to the cases you're talking about, where on the outside, the cover of the book doesn't look so bad. You have the opportunity to intervene. And the most important part about this intervention is that we can take the information here and give them actionable steps that they can accomplish. So, some more, we've talked about most of this stuff already. And I'm going to skip forward here because I really want to go to this next part. So I pardon for all those online. If you want to see my slides, go ahead and give me a shout out online on Instagram or you can email me. So the important part is our ability to intervene. And so I want to talk about another case of a young man, 27 years old. He came to me. He was overweight, metabolically unhealthy, insulin resistant, glucose intolerant, lipids a mess, so on. We put him on a program. And I said, you're working out too hard in the gym for what your testing is. He would go to the gym and he would get on the elliptical or whatever and get his heart rate up to 160 and stay there for an hour. And after we did his testing, I'm like, hey, I really need you to be in zone 2 because, your lipids are terrible. You're at high risk for cancer. You're at high risk for stroke. You basically almost have diabetes right now, and your kidney function isn't great. So, on our leading causes of death and disability, you're hitting a lot of these metrics. And I told him, I just need you to be at your heart rate of 104. Just get on the treadmill and walk at that. And, he really, that almost hurt his feelings, right? Because he wanted to feel like he'd sweat really hard and done everything. And he was just pushing himself up into zone 4, zone 5. And staying there for an hour, and he wasn't getting the results. And he called me the first day and he's all, Doc, you gotta be kidding me. I'm walking at 2.5 miles per hour on the treadmill. This is such a joke. And I'm like, I get it. Just do it. Just trust me. And he lost 4 pounds a week for the first 6 weeks because he was in that zone that helped him burn the fat and was where his mitochondria needed to be for his oxygen utilization and uptake for him to be able to do things. And he was like, you gave me the cheat code.
Sorry, Dr. Bennett, because I'm also looking at the questions that are being typed. So someone, Dana, had a question about how to improve mitochondrial function. Thank you so much for answering the question. I just want to highlight that what Dr. Bennett described, which is zone 2 training, is one of the most potent tools we have to resuscitate mitochondria. Zone 2 stimulates mitochondrial biogenesis and then triggers the ripple effect that's going to improve your metabolism across the board and so on and so forth. So obviously there's some other tools as well. Fasting is a good one. Cold exposure is a good one, etc. But by far the heavy artillery for improving mitochondrial function is zone 2 training.
So let's talk about that really quick. Let's really dive into zone 2. I have that slide in here, but I'm going to stop for a second. And I just want to talk through that. So let's talk about cellular adaptation zones. So first off, if you're calculating your heart rate zones, how's that normally done, Panos? It's 220 minus your age.
Exactly. Okay? Yeah. And then sometimes there are some, formulas that are a little bit more elaborate, but in almost every case, it's very
traditional. Yeah, that's the traditional way. And then you take 60 to 70% of that zone. That's your zone 2. Where did that come from? That came from 2 major groups of studies. One, military recruits, male military recruits finishing boot camp in the United States.
And that was way back when, right?
That was like when people were way more metabolically healthy, right? This is
exactly. 60s I'm pretty sure it doesn't even apply to military personnel today, because military personnel today is just so more, it's so different, so more unhealthy. Yeah.
Right. And which group, right? The Marine Corps that spends 16 weeks, 12 to 16 weeks, or the Air Force, which spends 4 to 6 weeks. Mm-hmm. Those groups are going to have dramatically different VO2 max findings, right?
Yeah.
Okay. Yeah. The other one that it came from was Division I NCAA college track athletes. So the very tippity top of track athletes in the United States, they took and they did a bunch of VO2 max testing on, and they said, oh, okay, well, it's top heart rate would be 220 minus your age, because I can push these 18-year-olds up to 200 heart rate. And that's crazy, right? That's not applicable to the majority of the population that's coming into the clinic. Okay. That is such a small percentage. And so that adaptation zone, we know if we do your breath analysis testing, your VO2 max testing in the lab, in college, or wherever, and then we have you work out in your zones, we get adaptation. And what adaptation is there? There's mitochondrial changes, there's glucose metabolism changes. You improve the AMPK pathway, you improve the SIRT1 pathway, you upregulate GLUT4 transporters, and you enhance activity of all the way down to PGC-1α, transport chains. So you do all of these things. So when you're working out in zone 2, you're decreasing inflammation, you're clearing your body of glucose, you're activating the protein kinase pathways that are able to move your fatty acids through, create ATP, and then move them through the electron transport chain efficiently. And everyone has to understand that their ability to deliver oxygen to the end of the electron transport chain is what determines how fast you can put the fat through that pathway to burn it. You have the ability to burn so many logs per minute, and if you try and put more in there, it gums up the works. It makes it so that it doesn't work. And so that adaptation zone is so critical for you to be able to change your health in general, that if you do not use it appropriately, then you're really in trouble.
Absolutely. And I just want to highlight the fact that, zone 2 is this magical spectrum of exercise intensity that stimulates all these very important pathways, ultimately resulting to mitochondrial biogenesis and so on and so forth. But, every zone has its utility, right? There's a lot of people, for instance, with respiratory issues, lung utilization issues, cardiovascular issues that can benefit from zone 4, zone 5. And so, depending on the problem that the person is facing, the limitation, as I was saying earlier, the prescription changes, right? And so if you think about it, by far the most potent prescription that can be given to any person is going to be nutrition and exercise, right? These will account for, 95+% of the success of any treatment. And so being strategic and being, individualized and being limitation specific is critical. And applying a thought process that is scientific and structured is obviously important. And it's exactly what you would do if you were prescribing drugs, right? You would test to see what the issue is, and then based on some sort of widely accepted process, you would provide this person with a recommendation of what they need to take. Same exact thing applies to how we move our body and how we nourish our body. Just putting that out there for people to understand, the basic concept.
Food is absolutely medicine, and exercise is medicine. And it's so funny, when we get our diet from 0% to 50%, it's amazing what happens to people. Mm-hmm. If we can get half their diet kind of cleaned up, if we can get them to 80%, mm-hmm. they have massive mm-hmm. life changes. And mm-hmm. we use our device to figure out those major adaptation zones, zone 2 and zone 4, and then prescribe how we're going to utilize that in each case, how much, I call it foundation building in zone 2, and then how much we're going to expand our VO2 peak by using zone 4. I think this is a great place to start opening it up to more questions. We spent about 40 mm-hmm. minutes talking about things. Mm-hmm. I think we can dive into some questions because people always fascinate me they're very insightful.
Yeah. Let's start maybe from the beginning. Dawn is giving us a shout out for highlighting the fact that doctors are afraid of making mistakes, and we need to overcome that fear in order to actually innovate in the space. Dawn, aim into that as well. Looking at the MOOV website, it's not clear if there's an active location. I don't know. Donald, do you guys have a locator in your on your website?
Yeah, we do have 2 active locations, one in the Indianapolis area in Zionsville and one in St. Louis. And Don Davis, you can go ahead and give a shout out to us. We do have a locator, but yeah, great stuff. And I can provide my email, which is donald.bennett@moov.health. That's MOOV, just like it was on the slides.
Awesome. Thank you. And then Alan has a question about fat utilization in zone 3 and 4 with moderate to high intensity cardio and weight training over time. Well, fat utilization is going to be improved predominantly through your cardio training, like resistance training, super important, for muscle growth, improving bone mass, bone density, preventing osteopenia, all these, bad things. But obviously it can't do everything as a form of exercise. As I said earlier, the most potent contributor towards fat burn efficiency is going to be your zone 2 training. So how high can your fat utilization get after you do a lot of zone 2 training? For instance, if you're like a world sort of renowned triathlete, I would say that being considered perhaps the highest level of achievement when it comes to fat burn efficiency. We've seen up to 90 or 80% fat utilization throughout zone 2 and zone 3. So you can be a fat burning engine almost across the entire spectrum of exercise intensity. And then, as Donald mentioned earlier, on the opposite side of the spectrum of someone who's like morbidly obese, extremely metabolically unhealthy, you can, find someone who does almost zero of fat utilization in zone 2 and zone 3. So just to answer the question, the spectrum can literally range from 0 to almost 95.
And Alan, with Alan's question, it's really funny because it depends on the preponderance of types of muscle fibers that you have. So if you're more of a type 1 or a type 2 person, I see differences in our carbohydrate and fat utilization numbers. Where if you have the bigger, bulkier, natural bodybuilder type build, your fat utilization is different at lower zones compared to higher zones. And the people who are the thin, lithe, athlete who's obviously set to be an endurance athlete, you just look at their build and they are ready to be an endurance athlete. Their fat utilization, it has a preponderance that's different. So there's a genetic component. How are you set up with your percentage of muscle fibers? But the other thing that's interesting, because going back, I get this question all the time, how do I do this? And it's really about, in my opinion, avoiding zone 3 as part of your major training zone when you're trying to improve your fat utilization. I don't see, and I can't find much data on any successful programs where you really focus on zone 3 to improve your fat utilization. Zone 3 is more about
as a matter of fact, zone 3 is considered the dead zone. So a lot of people, especially trainers, but also now doctors who are familiar with the concept of zone training, consider zone 3 the dead zone, in the sense that you are getting a little bit of mitochondrial biogenesis, a little bit of fat adaptation. You may be getting some of the lung and pulmonary and cardiovascular benefits of zone 4, but it's really not the full deal in either side of the spectrum. And at the same time, however, what you're doing is you're exerting at a higher intensity for longer periods of time, and that is accumulating a lot of stress on your body. And so it's actually a very common mistake for people to be focusing on their zone 3, right? spending time in zone 3 while thinking that they are in zone 2, what they're going to end up doing is they're going to juice out their body because the intensity is significantly higher. Fat utilization is significantly lower. So in these cases, people are just burning out themselves. So, this is just another reason why people should know their zones if they're trying to make gains through that process.
Yeah. And the other part for those out there, you're going to be like, oh, well, I track my heart rate and I'm in zone 3. I go up into zone 3 and maybe past it and come back down while I'm doing traditional weightlifting programs. I'm not talking about HIIT and where you're really circling through. I'm talking about traditional weightlifting. Don't get so caught up on how high you're spiking. You want to look at your average heart rate over your whole weightlifting session. So if you're weightlifting for 30 or 45 minutes or an hour, it's more important about kind of that average heart rate, not where did you spike to. And if you're keeping your average really high, you may be not getting the benefit and the recovery that you need. And so I've been able to take bodybuilding and weightlifting people and blow through their previous maxes because we are doing zone 2 training now, not zone 1 training, but actually putting them in zone 2 training and then having them change their rest periods so that they come back down into zone 1 in between their lifts. And what does that do? That upregulates the total density of mitochondria per unit square of muscle tissue. It upregulates the capillary density per unit square of muscle tissue. And fascinatingly, we upregulate part of our calcium channel that's important for the myocyte contraction when we do zone 2. So we have all of these upregulation. Plus, we're upregulating GLUT4, which is allowing us to pull glucose in if we're overdoing it on our glucose load without even having to use insulin. And once we spike our insulin, we turn off our fat burning, which is the whole point of what we're trying to do.
Awesome. I think there was another question. Oh, yeah. Dana had a question about mitochondrial function and how to improve it. I think we touched upon that during the conversation. Can you give an example? A question from Dave. Can you give an example of VO2 Max testing protocols, and is treadmill the go-to device? As far as the protocol goes, it's pretty straightforward. You start with a warm-up, 3 minutes, and then you basically take the person through a graded test where you increase the intensity every minute on the minute for about 10 to 12 minutes, depending on the fitness level of the person. People who are more fit will be able to tolerate the graded test for a longer period and get to a higher intensity versus someone who's not as fit, but that's pretty much it. So it's a graded test. And treadmill is I would say most VO2 Max tests are conducted on treadmills. Some prefer the stationary bicycle because for people who have mobility issues or people who are not comfortable with running on a treadmill, it may be a better option, but you can do either or.
Yeah, we put both in our clinic. We have a treadmill and a bike to allow for people who have knee problems or knee replacements or ankles, or they just prefer being on a bike. Our trained triathletes or some of our biking athletes that come and see us, there's a whole group of people that just ride like crazy in the Uintas Mountains for competitive biking. They just love to come in on the bike, and so that then we dial in their wattage and are able to get a really great test for them, which correlates to how they work out. The other thing I want to talk about, there are some purists out there, and I wanted to get your opinion on this and bring this up for questions that say if you do a VO2 max test, it has to be fasted, and I'm talking about the peak performance, and it has to be without caffeine. And my biggest problem with this is that's not how people show up to the gym. And so I've gone back and forth looking at literature, talking with other experts, talking with my colleagues, that I think we should meet the patients at the condition that they're actually going to be utilizing the information. What's your thoughts on that, Panos? I know we're kind of diving into the weeds, but the purist would say
it's a very important topic. Yeah. And, I've been running this company for almost 8 years now. And when I started the company, I had no background in medicine or biology or anything. I'm an engineer. Mechanical engineer and, then software engineering at Stanford. So I had to actually do a lot of learning by connecting with experts, especially from the VO2 Max and cardiometabolic testing space. The reality is that most of the literature has been structured around fasted and caffeine-free testing. However, after talking to a lot of KOLs, what emerged as the consensus is that it's not a must. The important thing is to create consistency in the testing conditions so that you eliminate, first of all, differences between testing that may blunt the insights that you're trying to elicit. And then also timing is a very important thing. You need to make sure you're retesting people at the same time of the original test, because diurnal differences are actually a thing when it comes to our metabolism. So if you are testing people when you're testing people when they're in the same condition as they will be when visiting the gym or playing their sport or whatever, that's good, no issue. Just make sure that you always test them at this condition. So that's the biggest, the biggest must.
And that's what we teach our staff too. That's what we teach our staff is to do it that way, and to allow the client to determine the time of day that they want to come in. To match when they're going. So if they work out early mornings, we try and get them an early morning appointment. If they work out in the afternoons, we try to get them an afternoon appointment, and so on. So sorry to interrupt, but that's what.
No.
Yeah,
absolutely. I think it's a very important point. Maybe a little bit advanced for the audience today, but I think Dawn has another interesting question. I just wanted to highlight that for everyone. About the resources and the report that I shared, and a lot of the stuff that Donald shared. I posted a link on the web chat if people want to learn more, get access to all the material, the ebooks, our educational content. We put a lot of stuff out there. I posted a link if people want to sign up and schedule some time with us, and we can share everything and answer any other questions you guys have, because I know we're running low on time. Let me maybe
I have a couple. Oh yeah, I have a couple to answer. One, we do pre-screening for VO2 Max test. The PNOE put together a nice pre-screening that you have to answer before you can do the test. So that can flag people. And then of course we teach our staff, right? Like questions to ask. We have some other safety protocols on hand, about training and what to do if there's an emergency and so on. But people who have heart disease or who are elderly, they may also undergo, because I'm a physician and I sometimes get some very unhealthy people, they may need to go on into a more in-depth discussion with me, an assessment with me, or one of the other physicians, or one of our PAs or NPs, before we put them on the treadmill. So we have a subset of people, hey, I exercise all the time, it's good, I never have a problem, boom, they're off and they go. And then we have I've had some problems, and we do a little additional screening that our non-clinical staff is allowed to do, that's set up protocolized. And then if they fail or if there's any uncomfortableness, or if the person wants to talk to us, then they come and talk to one of the clinicians. And that's a lot different than what PNOE has out, from when we buy their device and utilize it, we're utilizing it in the physician resource, as opposed to if you're at a if you're a trainer or someone else, you want to proceed with caution, right? The last thing you want to be doing is calling for emergency to take someone to the A&E or the emergency room because you're trying to do these tests. The basal metabolic test, in my opinion, everyone could do. A person in the skilled nursing facility who's in bed, we could put the metabolic, because all we're doing is just having them breathe. It's probably a zero risk test. I guess you could risk getting an infection if you didn't clean the equipment or something like that. But really, there's zero risk. For whoever asked, how do we screen? That's what we do. We've put together an internal policy because we're physicians and we're doing a different subset. I'll let Panos give you how PNOE has recommended it.
Yeah, so you can use PNOE in a medical setting, a fitness setting, a wellness setting. We have clients that range the entire gamut from hospital systems all the way down to nail salons. So it's a test that can be administered everywhere by anyone for as long as they've gone through the basic training, which is not really that much. The RMR testing, the resting test is, as Donald said, very easy to administer. Almost anyone can do it. Now, the VO2 Max does require a little bit more, training, not because the device is harder to utilize in this test, but it's more because you need to know how to take the person through the protocol. It's more the process that requires a little bit of training, but again, nothing crazy. But yeah, for as long as you're testing people that are have diagnosed conditions that would prevent them from exercising freely, then obviously you need to have a doctor on site. That's not because of the PNOE test. That's because of the fact that you're doing a stress test. So even if you weren't using PNOE and you were putting them on a treadmill, you would be required by law to have an attending physician on site. So that's just something to consider besides PNOE. But yeah, that's pretty much it.
Perfect. And then let's talk about, someone asked a great question, and this is just for those who are doing it. They asked, how do you know to test somebody kind of on the beginner setting, the easy, hard, and so on? And one that comes with doing the assessments over and over again, you understand what level people are at, but it's pretty easy to get an idea when you start asking them how fast can you run 3 miles, or do a 5K, when you're on your bike, what are your output? And so the more adept athletes you can put at higher settings, people who just haven't been working out very much, it's pretty easy. Put them on the easier beginner settings, and those work. And really, you could start anybody at the beginner setting. You just might be doing the test for 25 minutes, which is just painful for everyone involved. And that's kind of if you err on the side of, I don't think you're as good as you said you are, your test goes a little bit longer.
Yeah. Cool. I guess we are sort of out of time. I know people may have additional questions, and that's why I posted a link that people can use to schedule time with us. I also mentioned the website of our company, PNOE. You guys can visit the website and download the ebook there, or schedule some time from the website. It's totally up to you. But I think other than that, I would like to thank Dr. Bennett for taking the time and sharing all of his insights about the work that he's doing. We're very grateful to have you as a customer and an ambassador, and for all the work that you've done.
Panos, it's been great, and thanks for giving all my questions life way back when I contacted you and was trying to figure all of this stuff out. Your team's been fantastic and really helped me learn so many things. So and then I people out there, happy to share my knowledge and kind of what we were learning. So
awesome. Thank you everyone for joining, and have a good one.